Good morning. Welcome to Senate Health and Human Services. I'm going to ask Senator Long if he could lead us in the Pledge of Allegiance.
Flag of the United States of America and to the republic one nation under God, indivisible, with liberty and justice for all.
I'm going to open the hearing on Senate Bill 129 relative to establishing an uncompensated health care fund to be administered by the Department of Insurance and assessed by a surcharge on commercial insurers, reinsurers, and trusts overseeing self-insured plans. We've got Grant Bossy for the prime sponsor.
Thank you, Chairman Rochford, members of the committee. My name is Grant Bossy, Deputy Chief of Staff of the New Hampshire Senate. I'm here to introduce SB 129 on behalf of Senator Dan Innes, the bill's prime sponsor. Through the Disproportionate Share Hospital Program and Granite Advantage, this legislature has done a lot to offset the costs of uncompensated care at New Hampshire hospitals and clinics, but uncompensated care remains a large financial challenge for our healthcare facilities. These costs get passed along to paying customers and into health insurance rates. So Senator Innes was happy to introduce Senate Bill 129 at the request of community mental health centers in his district in order to continue to attack this problem. Unfortunately, the final bill was not exactly what he had in mind. Fortunately, there is an identical bill coming up next on the docket, and Senator Innes thinks Senator Altshuler would be a much better carrier for this particular issue. He would ask that you ITL his bill and consider Senator Altshuler's bill in its place. Thank you for your consideration of Senate Bill 129.
Great, thank you. So for those that, just to understand what's going on, we have a Senate Bill 129. We have an identical bill, as I said earlier, 136 by Senator Altshuler. Those that have signed up to speak on 120, you're totally welcome to do that. I would recommend, though, that if you could save your testimony for 136, we will, in light of the fact that Senator Innes has recommended that's the vehicle that we use. So thank you very much.
Thank you.
So with that, like I said, you're welcome to speak on 129. If there's anyone that would like to do that, we can do that. Otherwise, we'll save testimony for 136. Okay. Yep, let's close the hearing on Senate Bill 129. We have a motion to exec. Do we have a second?
Second.
All those in favor say aye.
Aye.
Aye. In executive session on 129.
Move to ICTL.
We've got a motion ITL. Senator Long is the second. Any further discussion? All those in favor say aye.
Aye.
Opposed? No. Consent? We've got a motion for consent by Senator Avard.
Second.
Senator Birdsell, second. All those in favor say aye.
Aye. Motion to move out of exec?
Yes, do you want to take it out? All right, Senator Avard will take it out. And we have a motion to come out of exec.
Second.
I think you were the motion. Senator Birdsell's the second. All those in favor to come out of executive session on Senate Bill 129 say aye.
Aye.
Did you get all that, Sophie? All right, very good. So we will be at 10:30. We'll open the hearing on Senate Bill 136. So we'll recess until then. open the hearing on Senate Bill 136, establishing an uncompensated care assessment fund and committee within the Department of Insurance. Welcome, Senator Altschiller.
Good morning. Thank you, Senator Chairman Rochford. I appreciate the time here. And my name is Deborah Altschiller. I represent District 24, the seacoast towns of Exeter, Stratham, Greenland, Rye, Hampton, Northampton, and Hampton Falls. And I'm here to introduce Senate Bill 136, establishing an uncompensated care assessment fund and committee within the Department of Insurance. And by way of explanation, just to smooth over some of the rough edges from there being two of these bills and one being withdrawn, I want to let you know that this is a project and an issue that I believe Senator Innes has been working on in his community, and I have been working on in mine. And we put forward the same bill, and I was under the impression that I would be co-sponsoring his, and then I thought he missed the deadline. So I quickly got this in and asked him to jump on and thought, oh, missed another ships passing, and then I missed the deadline. And then what do you know? Here we both are. So nonetheless, what became apparent in working through this bill is that there are two words missing from a couple of places in the bill, which may clear up some of the confusion that is bound to come behind me, not the least of which was apparent in the fiscal note. And I would ask the committee to, as we go forward, consider an amendment that adds the words mental health. In line 2, the general court recognizes that because a major contributor of uncompensated mental health care costs, this entire bill is about mental health care costs. And I fear that in working within that small industry and with those providers, that we developed a little bit of a shorthand, knowing that we were all talking about mental health care and neglected to think about, oh, we need to talk about that independent from other kinds of health care. This bill is only about mental health care. So that hopefully will set the stage. And where you see, perhaps on line 16, the insurance department shall establish an uncompensated mental health care assessment. This is all mental health care. So with that moving forward, good morning. The New Hampshire 10-year mental health plan leans into the work of our 10 nonprofit community mental health centers. Within that plan is the Mission Zero project. And in the back of your testimony is the flyer for Mission Zero as seen on DHHS website to give you a little refresher about what Mission Zero is. Within that plan, Mission Zero is a collaborative effort to eliminate hospital emergency department psychiatric boarding. Since the state began this project in February of 2021, we have achieved Mission Zero twice, December 6th, 2024, and happily, this past weekend. This work took an enormous amount of time, effort, resources, and focus. A whole host of prevention, rapid response, and focus on patient needs with reduction in emergency department boarding. And we can't stop now. It's working. I am in regular contact with my community's mental health providers, and they report that they and their colleagues across the state are stretched altogether too thin to keep up the good work that we have done so far. They are providing care for our most vulnerable, and underinsured people, and this comes at a significant cost. In fact, our 10 nonprofit community healthcare centers had combined uncompensated costs of nearly $15 million in fiscal year 2024. This accounts for 12% of the total Medicaid revenue of the 10 community mental health centers, nearly double what it was in 2021.
These mission-based nonprofits, which are state-designated New Hampshire providers, care for more than 50,000 patients in the Granite State. In an analysis done by the CMHCs, they found that, quote, the main drivers of the CMHC's uncompensated care costs come from bad debt and write-offs from providing important and medically necessary services that are not paid for by commercial insurers, uncollectible patient debt that results from high deductible health plans for individuals who self-pay with no insurance, and providing services to patients who are in and out of Medicaid each month, also known as the Medicaid spend-down population. Another quote from their report, the payer mix for the CMHCs is primarily Medicaid, but includes commercial payers, insurers, and patients out-of-pocket payments. While the commercial and private payments are a smaller part of the payer mix and resulting revenue, they are a very large contributor to the uncompensated mental health care. This shift of costs from commercial payers to the nonprofit community mental health centers is causing a significant impact on the operational ability of these important community-based safety net providers. The effect of this is that the community mental health centers are designated as safety net providers, but they get no safety net funding. Providing care and being paid for it is the goal. Providing care and not being paid for it, as we do now, is unsustainable. I have attached a breakdown of the uncompensated care that's been provided. It's on the back page of my testimony. And respectfully, I ask the committee to recommend Senate Bill 136 ought to pass to support the work of our community mental health care providers across the Granite State. I'm very pleased to be joined by a staunch advocate and the executive director of my community mental health care center, President and CEO Jay Kuchar of Seacoast Mental Health. And I'm also pleased to have Dr. Cynthia Whitaker of Greater Nashua Mental Health here, and they are going to provide you with more details. I appreciate the committee looking through this legislation with fresh eyes and knowing that it is only about mental health care. And we are in service to providing those wraparound services, the preventative care, and keeping us at mission zero for as long as we can. Thank you.
Great, thank you. Any question, are you open for questions, Senator?
Sure,
right.
depending on what it is, I may defer to my colleagues behind me.
Just a
Let
quick
me go back,
question.
yeah,
Thank you, Senator.
certainly.
Lastly, the department's, I'm looking at the fiscal note assessment for this bill. With larger than existing basis is also undeterminable, but assuming approximately 550,000 covered lives. So we're looking at $553 million would be needed.
I'm sorry, where are you looking at that?
On the fiscal note on the back page. Is that, I'm just asking if that's correct.
Yes, so thank you for bringing that up. First of all, the information that was provided to the Department of Information, the Department of Insurance, was clearly not enough, and there's some extrapolating in here, not the least of which is that this fiscal note applies to all uncompensated medical care across the state. We are only looking to provide uncompensated mental health care. So this fiscal note does not match the ask
Thank you.
in any way. Thank you. Not to mention the fact it's a little editorializing, and didn't ask for that either, but here we are. Hopefully, we will get a secondary fiscal note that will accurately reflect some of the breakdown that you have on the back page of your testimony, and which is a significantly smaller amount.
Thank you. Any further questions? No, thank you very much. It's
Wonderful.
amazing what 2 words will do, right?
I know, right? Yeah, thank you. I appreciate your grace on that.
Thank you.
I think line 11 too on the. Wrong.
Nope, we can have that as well. Right. Thank you, Senator. Next person, actually, I'm going to call Jay Kuchar and Cynthia Whitaker. Good morning.
Good morning. Good
Welcome
morning.
back.
Yes, thank you. Good morning, Chairman Rochford, and other senator esteemed members. So yes, I am Dr. Cynthia Whitaker, a psychologist by training. I've had the privilege of devoting my entire career to the community mental health system in our state and currently serve as the president and CEO of Greater Nashua Mental Health. Jay Kuchar, who is with me, is the president and CEO at Seacoast Mental Health Center. And there are other CEOs from the other community mental health centers here who have joined us today. So we all together, the 10 of us, are part of the New Hampshire Community Behavioral Health Association. And that association helped pull all of the data together and the paper that you have before you, that's attached with our testimony. So we are here, of course, to strongly support Senate Bill 136. And we appreciate the opportunity to talk with you about the impact that uncompensated care has had on us as centers. As you've heard, we are the safety net for community mental health, but we don't have safety net funding. Over many years, as we've collaborated with the state, we've found ways to manage that, mitigate it as we could, and it had been very flat for many of us. But with some of these new things that have happened with the Medicaid unwinds, with the impact of people shifting with granted advantage and what is covered and what isn't covered, as was mentioned, our uncompensated care has expanded significantly from over just a past of the few years ago. My center in Nashua, as an example, for many years, decade, we've had $1 million of uncompensated care year after year after year. Last year, unexpectedly, it was $2.5 million. We had no way, our philanthropy can't take that, our asks of our municipalities can't mitigate that. And so we ended up using money that we would have been using to create a brand new community center in our town, in our region, to set that up. And so now we've needed to delay that capital project because we needed to put the cash to fund the uncompensated care. Now, often people say, well, what's the business behind that? We have somebody that's very outspoken saying, we don't know how to manage that business of uncompensated care. The difference between private practices that are, they have the ability to say no. We, by statute, are required as a partner with our Department of Health and Human Services to provide mental health care to all of our constituents across the state, regardless of their ability to pay. So by law, we need to do this to be the safety net for our community, but yet we're left in the lurches without funding to do so. So we're highly in support of this happening. We believe that we are part of the impact of Mission Zero, but if we don't have help in mitigating this uncompensated care, there will be impact on our ability to staff these services. We might be looking to decrease the availability of these services at the very time the state is asking us to step up to make sure that the state meets its requirements for the Community Mental Health Agreement as well as the Mission Zero Agreement. Our colleague, Roland Lammy, who is the executive director of the Community Behavioral Association, is going to speak to you about the breakdown of the funds, where it comes from, and how we got to where we are in this proposal that the senator has put forward for you. And I think with that, I will say we are open to your questions.
Any questions? I have a quick question here. So looking at the way this bill is structured, it looks like we have an uncompensated care model for hospitals. And we charge an assessment, Medicaid enhancement tax. And this may be a question for DHHS, but they're not on the list today. So you're lucky enough to be the one that's going to get the question. If you don't know the answer, I'm fine with that. So it looks like the language of this bill emulates that program that we already have existing for hospital stays. And the assessment that is the tax, they call it the Medicaid enhancement tax, that's the hospitals pay. It's used to pull down federal funds to go towards uncompensated care. Are you aware of any federal funds that are available that we could structure that out of, that we could get our hands on for mental health care?
I think we would need to defer to Roland Lammy.
Okay.
When he speaks.
All right, so Roland knows what question he's going to be asked.
At least one of them.
All right, very good. I don't have any further questions. No, thank you very much.
Thank you.
Thank you so much.
Roland? You weren't next on the list, but after that, you're next on the list.
That's quite all right. Thank you. Great. Well, Chairman Rochford and members of the committee, thank you for the opportunity to speak with you here this morning. My name is Roland Lammy. I'm the Executive Director of the New Hampshire Community Behavioral Health Association. I have been in that role for over 20 years, and largely my role is to assist the community mental health centers with payer-related challenges, third-party payer-related challenges from both the public sector and the private sector payment. I'm proud to say that with respect to our Medicaid system and our Medicaid managed care relationships, we have developed an alternative payment model that is unlike anything that exists anywhere else in the country. We've done that through collaboration, and we've continued to improve on that model very recently in collaboration with the Department of Health and Human Services and its Medicaid leadership. I'm here today to talk to you a little bit about the growing concern of uncompensated care for the 10 mental health centers. And my goal is to orient you to a spreadsheet that should be in your packets that looks a little like this. Okay. Keep in mind that as we walk through this spreadsheet, that mental health centers are largely dependent on Medicaid revenue. On average, about 75% of the revenue to a mental health center is from Medicaid revenue. And that varies across the state from high 60th percentile to low 90th percentile. But what that means is that there's an inability of these providers to cost shift, unlike some other providers in the healthcare system. When services are provided virtually for free, there is no other way to compensate for those services by shifting the burden to other payer sources. This simple spreadsheet in front of you is from data that I collected recently from the 10 mental health centers, and I just wanted to orient you a little bit to that spreadsheet so you have a little bit of context to the size of this problem. The top portion of the spreadsheet provides you with the aggregate uncompensated care for each community mental health center across the state. You'll note that it provides you from fiscal year 21 to fiscal year 24, and you can see the rate of growth in each of those centers in uncompensated care over that time frame. The sections below are the sections that we created to try to understand this uncompensated care problem, where the source of the uncompensated care was coming from. The first section is in our spend down program, sometimes referred to as the Medicaid in and out program. That's New Hampshire's program where consumers have to spend or have qualified expenses in the beginning of each month in order to qualify for Medicaid after. And they generally do that through seeking services at community mental health centers or sometimes seeking services at hospital emergency rooms, and generally not covered or not collected or are unable to be collected for payment for those services. So that first section is the spend down section. You can see the growth in that section as well. The second section is the cost shares that patients have, either self-pay, deductibles, co-pays from commercial coverage, Medicare deductibles, et cetera. And that will make up the second section that you see there in bad debt or uncompensated care. About 3 sections down, you'll see a section that addresses services that are provided to chronically mentally ill patients. These are services, as Dr. Whitaker noted, that are ordered by the doctor, but not necessarily paid for by private insurance coverage. They're generally referred to as home and community-based services and supports, as well as critical case management services. And these are designed to keep patients out of higher cost settings of care, keep them out of the emergency room, keep them out of inpatient care. And our state and federal government considers these medically necessary services to be provided to consumers who are chronically mentally ill. We provide those irrespective of ability to pay because they are a core component of the patient's care plan. At the bottom of the spreadsheet, you'll see total Medicaid revenue and then uncompensated care as a percentage of the total revenue. These total revenues are for Medicaid revenue. As I mentioned, that's our largest payer source, definitely our best payer. You might note that one of the things that I wanted to highlight in this spreadsheet is if you look at the Medicaid revenue from 21 to 24, you'll see a decline in Medicaid revenue across the system. And if you go to the top section, you see a rise in uncompensated care. It's a little bit of a double whammy. Interestingly enough, if you total those two variances, that is about the total of our system operating losses in fiscal year 24. So 9 of our 10 centers had operating losses that in total approached roughly about $20 million, just shy of $20 million over fiscal year 24. It was a significant hit to our system. I wanted to also point out that each area here, if you look at each section, you'll see significant growth in uncompensated care. And we've definitely noticed in our system a rise in the prevalence of chronically mentally ill patients with private insurance coverage. And while we've known forever that mental illness has no economic bounds, this trend is certainly concerning and unsustainable for our system of care. The state of New Hampshire, has, like many states, has existing programs for uncompensated care. You mentioned a few of these. There are specific programs for specific providers, things like nursing homes and hospitals that have specific ways and mechanisms to address the uncompensated care burden. This bill is one solution. While we believe it addresses the core of our uncompensated care program, our uncompensated care problem, we certainly remain open to other solutions. This is just simply one mechanism, and we think that this bill in front of you will assure some sustainability of our system of care. We have met with the Department of Insurance. They've offered us some feedback. We're certainly willing and ready to work with them as we move forward. If they're willing to work with us, we know that mental health care is certainly a priority for Commissioner Betancourt, and we appreciate the work that he's done over the last few years in this space. As you'll hear from our providers or other providers, uncompensated care weakens the stability of our system. Everyone, including insurance companies and the grant estaters they cover, will benefit from a strong outpatient system of care. But this uncompensated care crisis is weakening our system, it's delaying access to care, and it challenges our ability to provide adequate outpatient care to do things that are contemplated, for example, in the Mission Zero program. We have a history in New Hampshire of using assessments to deal with tricky healthcare situations. We use them to fund vaccines. We use them to fund the state reinsurance pool. We use them to fund programs like Medicaid expansion or the Granted Advantage program. And so we think that this bill has synergy to those other mechanisms where we're trying to address tricky issues. To get at your question to Dr. Whitaker, this program contemplated in this bill is not like the Medicaid enhancement tax that you referenced, because the Medicaid enhancement tax is a tax that's done on gross revenues and then matched with federal funds. This program is more about assessment of commercial covered lives, creating a pool of dollars to offset uncompensated care. I believe it's similar to RSA 404, where you'll see an assessment mechanism created for the state reinsurance pool, as well as the subsidy to the Granted Advantage program. So I hope that helps clarify. It is definitely separate and different than the Medicaid enhancement tax. So I appreciate the opportunity to speak with you. I hope that helps orient you to the spreadsheet, and I'm happy to answer any questions.
Senator Yvonne.
Thank you, and appreciate your testimony. So basically, this is going to help out with cost shifting.
Yeah, I think the cost shift right now is just directly to our community mental health centers. You know, in other facets of the healthcare system, sometimes you're overpaid in maybe private pay or other things that try to help offset uncompensated care like this. In our case, we have a very small portion that's not Medicaid revenue. And so we can't negotiate higher prices in that 20% that's left to pay for this, cost shift it and pay for this.
So follow?
Yeah.
Yeah, so the assessment, who gets assessed?
The assessment that this bill is contemplated on works very similar to those other ones that I mentioned. It assesses roughly about 500,000 insured lives in New Hampshire to create a pool to fund this uncompensated care in the mental health centers.
Thank you.
Any other questions? Thank you very much.
Thank you.
Andrew Hosmer.
Thank you very much, Mr. Chairman and members of the committee. My name is Andrew Hosmer. I represent Harvard Pilgrim Healthcare, which is New Hampshire's largest nonprofit health insurer, with a mission to ensure that all of our members have access to high-quality healthcare coverage and services. And this is accomplished through dedication to offering a wide array of robust plans to our members, as well as building and maintaining strong relationships with our provider community. Harvard Pilgrim Healthcare is opposed to SB 136. We share the concerns with ED boarding and certainly support the goal of functional zero, making sure that all of our members, as well as all Granite Staters, receive the proper care at the proper place at the proper time. So we believe, from our perspective, that it's unreasonable to place the blame of uncompensated care on commercial carriers. Commercial carriers cover a broad array of clinical and medically necessary services that are reimbursed to providers throughout the state. The bill before you does not include a definition of uncompensated care, could include a wide variety of costs. I would like to point out to the committee, on the fiscal note, the work provided by the insurance department, and on second page of the fiscal note, paragraph number 2, the insurance department states the term uncompensated care is ambiguously defined, potentially encompassing a wide range of costs such as care for uninsured patients, unpaid cost-sharing amounts, or even services not deemed medically necessary. For analysis purposes, I continue quoting from this document, the department assumes, quote, uncompensated care is limited to medically necessary care for uninsured individuals ineligible for government programs who do not pay for services. Concerns have been raised about the unintended consequences, such as disincentivizing insurance coverage and payment of medical expenses along with potential fiscal impacts. I will say that we have operated under the presumption that that is the proper definition of uncompensated care, indicating, and certainly we can share some concerns and empathize with our providers here who do a remarkable job in our communities, and that Medicaid reimbursement, if it makes up 75% of the revenue stream to our community mental health centers, is not compensating adequately for the services that they're rendering to Medicaid patients. But the idea of charging insurance carriers an assessment, which is ultimately a tax to them to make up for this, we believe is wholly unfair and not the proper solution to a really challenging problem. And I will once again say that all of our carriers in this state, and Harvard Pilgrim Healthcare in particular, is ready and willing and able to work collaboratively with all stakeholders to find solutions to this problem. But we feel that this problem, particularly in light of the fact that, let's say that this fiscal note is not accurate because we've made an edit. Looking at the last page of the fiscal note, it was determined that about $84 per member per month would be the assessment. Well, if that was for all uncompensated care, all medical, and if we were to reduce that to just mental health, maybe we would cut that in half, I don't know, at $40 per person, per member, per month. The total cost associated with that for a plan that covered 50,000 people might be upwards of $25 million. That would be the assessment. And I don't know of any carriers that are sitting on pools of money right now or where they could just draw that money down and somehow think that they are going to remain viable within the state. I think what this really does ultimately is destabilize our health insurance system within our state. It may ultimately result in higher deductibles and doesn't really solve the problem here that our community mental health centers are certainly looking to make up revenues, targeting our commercial insurers who have been very good collaborative partners with the state of New Hampshire, particularly when it comes to something like expanded Medicaid over the years and covering a portion of that. The idea of continuing to target is not really what I think the state should be looking to do. With that, I realize the fiscal note does need an update there, so the numbers we're looking at may be artificially incorrectly high. But I would say, taking a closer look at that and saying, this really is an assessment. It's truly a tax. It's a tax on a company that's doing its very best in a very highly regulated environment, very competitive, and this would really destabilize what we're trying to do in the state. I'm happy to take any questions that you may have, and I thank you for your time.
Great, thank you. Are there any questions? No, thank you very much.
Thank you.
Sam Hawkins.
Good morning, Chairman.
Good
members of the
morning.
committee. Thank you for the opportunity to testify today. For the record, my name is Sam Hawkins. I am the Public Policy Assistant at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. So you have heard that New Hampshire's 10 community mental health centers ensure that every Granite Stater is able to access the care they need, regardless of their ability to pay. You have also heard that these centers often face a generally precarious financial situation, driven in part due to uncompensated care. I do want to take a moment to emphasize the quality and the importance of these services. You have heard from me many times at this point about the mental health crisis facing our state. These centers are our front line in addressing that crisis. NAMI New Hampshire has heard that even for those receiving services who have commercial insurance, that they are receiving some services that are not covered and they're unable to pay for. I anticipate you may hear that this is because they are not medically necessary or they may be deemed social supports. However, we know from our members that these services are essential to their recovery and they are medically necessary. As we understand the situation, in this instant, private insurers are essentially passing on the cost of services for their beneficiaries onto the community mental health centers. To be frank, these centers are our safety net. There is nowhere else for some of our most vulnerable Granite Staters to go. We cannot afford to lose these centers or see a reduction in services, which means we need a solution to fund them. Senate Bill 136 does just that. And for that reason, NAMI New Hampshire asks the committee to please vote OTP on Senate Bill 136, and I thank you for your time.
Okay, thank you. Any questions? No, thank you very much. Oh, Senator Long, yes.
Thank you for your testimony. Could you reiterate a little more on what commercial insurances are being asked in this and where you differ from that?
Yeah, absolutely. So essentially, as we see the situation, there are patients under or beneficiaries under commercial insurers that are receiving services at the community mental health centers that are not covered by their insurer, but they're also unable to pay for. In this case, the community mental health center is uncompensated for that care. They have to pay for it. So essentially, the beneficiary of this insurance is receiving a service that is crucial to their recovery, but the insurance carrier is not paying for it. Thank you for your question.
Thank you.
If I may.
Yeah.
But what this would do is it wouldn't pay for, you're assessing a fee on the commercial carriers. And what you just said, it would, to pay for uncompensated care, but the fee would not only pay for their members, but everyone else, correct?
Thank you for your question. As I understand it, what is generated from this fee is largely focused at paying for that uncompensated care. So that situation where that I referenced, I'm not sure exactly as to whether money generated by this assessment would go towards other services, but I do believe it is primarily targeted at that. Yes.
We are talking about the same thing, uncompensated care, but you're assessing, the assessment is on private insurance to pay for uncompensated care, and that uncompensated care may not even be private insurance uncompensated care, but everyone's uncompensated care.
I thank you for your question. While that I do believe there is an instance of truth in there, I think so a lot of the patients at the community mental health centers qualify for Medicaid. Mm-hmm. So in those instances, we are seeing that care is being paid for by Medicaid. So the uncompensated care that the centers are faced with is slimmer because so much of their patient base is Medicaid. So we're seeing that slimmer instance of uncompensated care is those instances of these services that are not paid for by commercial insurance, as I understand it.
Okay, thank you.
Thank you.
Michelle Heaton, DJ Betancourt.
Good morning, Mr. Chairman, members of the committee. For the record, DJ Betancourt, Commissioner of the New Hampshire Insurance Department. I'm joined here at the table by Michelle Heaton, who is the Director of our Life and Health Division. Just to start off, a quick comment here about fiscal notes. So, two things. The first is I've really asked my team to try to provide you all with substantive information. And so our fiscal notes tend to include a little bit more detail than maybe some other departments provide you with. But for me, I know that when I was in the legislature, it was always a little bit frustrating to get fiscal notes that didn't tell me a whole lot, didn't really give me much to work with as I was considering the proposal that was before me. So we try to give you a lot of information. It's not intended to be editorializing. It's just me trying to do right by all of you as you guys make important policy decisions on not only this bill, but others, of course, as well. And the other is that I've really instructed my team to just keep the analysis to how the bill is written. It's hard for us, obviously, to try to get into the minds of senators and representatives as to what they intended the bill to do or not to do. So we do the analysis based on how the bill is drafted. And in some cases, that results in some scary fiscal notes. But if you work with us, we can tighten them up and we'll redo the analysis for you. So I know that Senator Altshuler mentioned that there were some words she had forgotten in the original drafting of the bill. My understanding is that with that clarified, it will change the analysis quite a bit. So it does matter sometimes. And just, again, anytime you have a proposal or an idea, we're always happy to work with you to draft the bill to make sure it's accomplishing exactly what you want it to accomplish. And so, again, you don't have this inadvertent situation where you've got a big, scary fiscal note that ends up getting attached to your bill when that was not what you intended to have happen. So that's the fiscal note comments I had for you. I've really appreciated the opportunity to work with the providers to better understand this issue. Senator Rochford, you commented earlier that I think we're all familiar with the concept of uncompensated care within the hospital context, and That's how I always understood it. I didn't appreciate what some of these providers are struggling with until we were able to have some good conversations with Jim Monahan and Roland to get a better understanding as to what they're experiencing, the challenges that they're going through as they approach their own particular kind of uncompensated care problem. So Michelle's going to do the analysis for you, and she'll probably be able to speak to some of the adjustment we think will be made as a result of the correction as it pertains to the fiscal note. But I will tell you that as a general matter, I am not a huge fan of assessments. Now, there are exceptions to every rule, including in a few minutes when we hear Senate Bill 128. Because my biggest concern is the impacts over time of those assessments on cost. And New Hampshire right now has the lowest average monthly premium in the country. We've earned that distinction, and you've been a huge part of that by making policy decisions that have helped to contain costs and not to have upward pressure on premiums. And so we're always very sensitive when there's the potential that we might lose that distinction, because at the end of the day, for me, one of the biggest, if not the biggest, barriers to access to care is cost. And we've done a good job of that in New Hampshire. We can always do better, and we're trying, but we've done a good job of it here. And so it's always a bit of a concern for us. Ultimately, at the end of the day, it's a policy decision for you all to make. But do appreciate the fact that, again, nothing I think is more inaccurate than when I hear people say, well, you know, the insurance companies can afford it. Maybe so, but that's not how it works. They're going to incur that cost, and they're going to pass it on to the consumer in some form or fashion, either higher premiums, higher deductibles, a narrowing of some coverages. They're not just going to eat it. So you've got to appreciate that the consumer will feel that in some way. But if you're going to go down that path, then I think you've got to make sure that you've got controls and guardrails in place to contain those costs. And so, yes, the fiscal note does make reference to the fact that the definition of uncompensated care probably needs some detail, some more meat on those bones to, again, ensure that you're controlling the cost. I would point out the retaliatory issue as well is very real. I don't think anyone here is on Ways and Means, but we always have an interesting conversation with them when, for at least the past couple of years, the insurance premium tax revenues have come in well over what we estimated, and it's because we've gotten some help from some other states. I won't mention any names, but New York, California, Massachusetts, who increase assessments, increase taxes, increase fees, and so as a result of that, we retaliate against them for that, and we take in greater revenue than we predicted. And so you've got to factor that in as well. It's very, very real. This is a difficult challenge. I have great respect for the providers that are struggling right now. It's a very, very difficult challenge. You know, I really work hard as commissioner whenever I'm in public to remind consumers that when you are in the individual market and you go onto the exchange to pick a plan, don't immediately jump to the plans that have the lowest monthly premium, because there's always a give and take in that dynamic. The lower the monthly premium, the higher your deductible is going to be. And people have to appreciate that, because as I understand it, it sounds like part of the struggle that the providers are having is that people who have coverage are not paying their deductibles, and the providers are being left to eat that cost. That's a tough challenge to address. And you certainly don't want to do anything that's going to incentivize people not to pay their deductibles. I think the other part of the struggle here, as I understand it, is that some of the services that we're talking about here are not typical medical services within the mental health space. So they're being deemed not medically necessary, and so therefore the commercial insurance carrier is not paying for those services. And again, it's interesting that we've got Senate Bill 128 coming up next, because there's a whole history behind those particular services and attempts in the past to mandate those services. And obviously that conversation is shifting in a different direction. but that issue, I think, is present here as well. So I'll stop rambling and I'll turn it over to Michelle to go through her analysis.
There's just a couple of technical things that I'd like to flag. In section 2, paragraph 2, there's reference to State of New Hampshire Health Plan. New Hampshire Health Plan is actually an organization that is statutorily created. And I think what's intended here is the State of New Hampshire Employee Plan. So I just might want to clarify that, what the intent is there. Yes.
What section are you talking about?
It's section 2, paragraph 2, lines 18 to 19.
Thank you.
So that is the state employees?
I think that's what's intended. New Hampshire Health Plan used to be the organization that ran our high risk pool, and now it handles 404G assessments.
Man.
Yes,
And how
absolutely.
many employees would that be?
I don't know. I'd have to ask admin services. I think it's around 40,000, but that's just really a shot in the dark.
Thank you.
Also on page 2, paragraph 5, which is lines 13 through 15, it states that the costs for uncompensated care assessment shall be treated as non-recoverable costs by carriers and shall not be passed on to individuals or employer groups. I'm just not sure how workable that really is. Most health insurers have, on average, a profit margin of 3%, and they're not allowed to absorb these types of costs. And I think the bigger issue here is the bulk of who is in this assessable class is self-funded groups. So they are responsible for covering their own costs. So they would have to absorb it, and they don't pass it on because they're the ones that have to cover their own costs. So I'm just not sure how that language could work in this context. Do you have a question?
It almost sounds contradictory.
Yes. It's saying you can't pass it on, but the self-insured group is responsible for its own costs. So they would have to absorb that cost. There's no one to pass it on to. Sometimes they'll use a TPA, but that TPA is not covering the cost of the plan. So there's no way to say you can't have the employer responsible for this. This would be a cost to the employer.
So there's no vehicle to assess then?
No, they'd be able to assess it. It's just, I think it's getting to the point that you can't pass this on as increased premium or projected claims costs. And I would say if you're a self-funded employer group, you're responsible for all the costs associated with the plan. So you're going to be liable for this. And I don't see any way around that. It's going to increase their overall cost because there's no one assuming the risk on their behalf. For the commercial insurers that are assuming the risk, there's a potential it could work. I don't know. I think there's going to be some legal arguments there that could be challenged. But you also have to keep in mind that they have only a 3% profit margin there. So there's not that much money to really play with. Also, just want to flag that when, I think we've talked about this a lot, but the idea of uncompensated care, it'd be very helpful if you could better define exactly what we're talking about here, because in paragraphs 9 through 13 on that page, the department is being tasked with paying out the funds, and without more parameters on exactly what we're supposed to be doing, you're putting a lot on the department and a lot of discretion into what exactly this uncompensated care is and what should be paid. And I think there are some legitimate differences of opinion when we're talking about uncompensated care and traditionally what that means in the context of insurance. On the fiscal note, we were under the assumption that uncompensated care was all uncompensated care, and that's why it was an estimate for uninsured people. It did not include costs that I think we've heard some testimony about cost sharing that's not being paid. Generally, we would not consider that uncompensated care because the covered person is contractually obligated to pay those costs under their insurance contract. So if we had more parameters around what uncompensated care were and we limited it only to mental health, I think it's still unclear if we're talking about just the community mental health centers or if we're talking about all mental health providers in the state. But if we had more of those parameters, we could do some additional analysis. I think the assessment of covered lives, that is a rough estimate because it's based off of, there's been reference to some of the 404G assessments. Those are very different assessments. I don't think they're comparable to this at all. But under the 404G, we have around 500,000 lives. So that would not include the state employee plans and doesn't include municipal plans as well, which this bill would. So the assessable lives would likely be a little bit higher, but we don't know exactly what that would be. And then we don't know exactly what this uncompensated care amount is. I mean, we're hearing numbers thrown out. If it was 20 million, then that would be 20 million that we would need to come up with in assessments. I'm happy to answer any questions.
Go ahead.
If I may, yeah. So it's more than potentially 40,000 individuals. It could be up to 600,000 individuals.
Yeah, we don't know how many covered lives. Right now, under the 404G assessments, that includes commercial insurance that we regulate, so individual, small group, large group that buy their commercial plans, and self-funded plans that have stop-loss insurance. Not all self-funded plans have stop-loss insurance. So that pool is approximately 500,000 lives. But with the state employees and the municipals, I don't know how much more, but it would be an increase.
Yes, go
Based
ahead.
on previous testimony, this could also be destabilizing. How could it be destabilizing? Is it for the insurance companies having to pass this on? Is that the point where?
Yeah, I think that language that I was pointing out to about them not being able to pass it on in higher premium, I'm not exactly sure how that would work, but if it was workable, that means that's eating into their profits. If they only have a 3% profit margin to begin with on a good year, assuming all their estimates work out as they planned, there may not be that much money left. I know in our individual market, we currently have 4 carriers, so it's probably the healthiest market it's ever been. We have record enrollment, but if we were to pass assessments that are eating into their profits, it may not be feasible for them to continue. I think as well, when we were talking about the amount of money in the original fiscal note that would need to be come up, then yes, that would definitely be destabilizing to the market. I think with updated analysis, if we're talking 20 million, that's a lot less than 550 million, but it's still an impact.
May I have one more?
Absolutely.
And that 20 million is ongoing, right? Every year after year after year.
I believe so.
Thank you.
I would just add, obviously, I want to be clear. I'm not trying to be in any way, shape, or form insensitive to the struggles that these providers are having. I don't think anyone wants to see them face these challenges or not get the compensation that they're entitled to receive. And at the end of the day, I'll stress again, it's a policy decision for you all to make. I've expressed the concerns that I have, but if you come to me and say, Commissioner, we appreciate your take on it, but we've weighed out the pros and the cons of this and we want to move forward, then we will certainly work with you on the language to make sure that we address some of these issues and that exactly at the end of the day what the cost is going to be. You'll have an accurate understanding of that cost, and you can decide, again, if you want that to ultimately be worked into premiums, because that's ultimately what will happen. But you may determine that that's a result you're okay with in exchange to ensure that the providers are getting the support that they need. Again, that's your decision to make. My job is to give you the information that I think you should be aware of as you make that decision. But I pledged that I would work with the providers on this issue to the greatest extent that we could. And I obviously make that same commitment to you as well.
Thank you. Any questions? Senator Long.
Thank you, Mr. Chairman. So is the insurance department able to articulate the uncompensated care just for the mental health centers as to the uncompensated care that are getting insured premiums, are the insurance that the insurances are creating, and also the not insured? Could that be divided? Will you be able to get that information?
So we don't have the fiscal information from these community mental health centers, so we don't know what their numbers look like. I can say that for the commercial insurance that we regulate, all plans are required to cover mental health services. That being said, usually you have to be in network. So we have been encouraging, it's part of our behavioral health advisory committee and some bulletins we've issued recently. We've been encouraging all carriers to reach out to community mental health centers, to make sure they're in contract and to make sure those contracts are updated and try to work together. I don't know at this point how many of those community mental health centers are in network, but they are required to cover mental health services. That being said, there are some services that these centers provide that are not what would be considered clinical care that is traditionally reimbursed by insurance. So some of those, we would say from the insurance perspective, are more social services. So that's where those types of services sometimes would not be covered under commercial insurers. We did issue a bulletin on our website just this last year to try to delineate the codes that are applicable for insurance, and we directed all carriers to work with community mental health centers and mental health providers to give better guidance on how to bill out those codes. I know there was a lot of misconceptions around case management, and all carriers do cover case management, but they may have their own case management, and that's maybe a little bit different than with the community mental health centers, and that's why we've directed the parties to work together. Ultimately, it's a contracting issue, so.
And Senator, I would just add that, to be clear, a lot of the services that we're talking about are still very, very valuable services. They're still good services. But to Michelle's point, they would fall outside of the typical clinical care types of services that commercial insurance is designed and has traditionally covered. I will say, and you've heard this before, mental health is my top priority as commissioner. And over the years that I've been with the department, we've had a number of conversations with the carriers about better understanding some of these services and being open to covering them. I've encouraged them to really do the analysis of whatever you're going to pay for some of these less acute services today, you're going to save in costs when the individual doesn't show up in an emergency room or need a bed over at New Hampshire Hospital. So we've had that dialogue with them over a number of years, and they've been flexible. But there are some services that are just really outside of, as I've said, that typical definition of those clinical services. Is that fair, Michelle?
Although if I may.
Yes,
Chairman.
absolutely.
So you would have the data on what doesn't fall into clinical services. You would have that uncompensated care number.
What we would have data on are the services that are billable. So we have that in our claims data, assuming it has been submitted for those payers, we would be able to quantify how much care is being provided that is being compensated by the insurance companies.
Okay. So you wouldn't have.
We wouldn't have the stuff that
Be
they're
added.
either not billing for people who are not insured, or cost sharing that's not being recovered. Our claims data assumes that if there's a $50 copay, then that $50 copay has been paid, just as an example.
Okay, just one more if I may.
Yeah.
So you're working towards having the commercial insurance looking towards adding on some of these services that may you deem helpful. Do you know what cost those are? And do you know if that relates to the mental health centers only?
So that would be dictated by the individual contracts, right?
Yeah, what we have asked the carriers to do is to reach out to all the community mental health centers, all the carriers, to make sure that they have contracts to the extent they can enter into contracts, and to make sure those contracts are updated. We've also encouraged them to explore alternative payment models to maybe allow for compensation of stuff that doesn't traditionally fall into insurance, bundled payments, those types of things. But ultimately, it's up for the carriers and the community mental health centers to negotiate that contract and come to an agreement. And that's kind of, we've taken everyone that far, but it's up to the parties to contract.
Okay, thank you.
Very good. That's it. All right. Thank you very
Senator.
much. Christine Stoddard.
Four different areas. Four different, what's covered and what's not. How do they determine? And what's considered? Yeah. This is essential. But you can't determine between. We need more to define some of this stuff.
Good morning.
Good morning,
Welcome.
Mr. Chair, members of the committee. It's nice to see you again. My name is Christine Stoddard, and I'm the Senior Director of New Hampshire Public Policy at Bi-State Primary Care Association. We represent New Hampshire's community health centers, who are also defined as safety net providers, and I thought we were coming here today to ask for the definition or a clearer definition of safety net providers, not that the bill be limited to mental health. And that's for a number of reasons. So I apologize that we did not speak to the sponsor of this bill because I thought the other bill was moving forward. So my testimony can be applicable to both since they're identical. So community health centers are required by law to treat everyone regardless of their ability to pay or insurance status. They are also required by law to provide certain types of services. And in the community health centers space, this means that they have to provide what are known as enabling services that help patients increase their access to care. For example, if someone needs translation or interpretation services, if they're hard of hearing, we have to provide someone to the patient so that they can access their care in a way that works for them. These services are not optional. We can't not provide them. They have to provide them. If someone is uninsured or underinsured, the health center has to slide their fee, which means if their patient lives at 200% of the federal poverty level, which is about $31,000, and they have a high deductible plan, the health center has to base the patient's payment on their income. So if they make $31,000, they pay a very small fee to the health center, and then the difference between what the patient pays and the cost of the care is what's called uncompensated care. And I would argue that there's also a very, I'm not an accountant, I'm an attorney, but there's an actuarial definition of uncompensated care that we would ask that we use because it's a common definition across the country for healthcare providers. So the reason why we would prefer that you define safety net providers versus just mental health, because you're going to capture non-safety net providers if you just say mental health in front of the words uncompensated care. And this bill, both bills are really targeting safety net providers. Also, federally qualified health centers, known as community health centers, also provide mental health services. It would be very hard for them to parse out their mental health services versus their primary and preventive care because we provide an integrated care model, which means we provide oral health services, primary and preventive care services, behavioral health services, substance use disorder treatment services. So it would be easier statutorily to just define safety net providers as the mental health centers and the federally qualified health centers. And the reason why you want to target those two types of organizations is because the law requires that they accept everyone, regardless of their ability to pay, as I said. The community health centers also have a large number of commercial patients. 36% of their patient payer mix is commercial insurance. The next biggest chunk is 31% of Medicaid, 19% of Medicare, and then 14% of uninsured. Their patients are uninsured for a number of reasons. There's not just one. They choose not to have insurance. They can't afford their high premiums. If they do have a high deductible, then the health center has to eat what that patient can't pay. In 2023, which is the most recent year that I have data for, the 10 community health centers that serve your districts had $14.5 million in uncompensated care. The chair's FQHC, Amanuenseck, had $2.8 million. Amanuenseck also saw a 25% demand increase in demand for mental health services in 2023. If we don't address the uncompensated care problem, the health centers have to close sites, and this is what they're doing. Over the summer, the state was able to use federal money to do what we called emergency stabilization funding. Because of the pandemic, because of the Medicaid unwind, the health centers and the mental health centers both incurred a large amount of uncompensated care. That was one-time funding, but the problem still exists. And the state, for whatever reason, has chosen as a policy to assess carriers, to assess tobacco users or products, to assess different types of entities to pay for health care. I'm not commenting on how the policy decision that you make. I'm just asking you, and our health centers are asking you, to fix the problem. How you assess the fee, we're happy to work with you on that, but the problem needs to be addressed. I would also argue that if we don't address the problem, you're going to be paying for it anyway through higher premiums, because when someone can't access cost-effective care or access care at their primary care provider, they're going to go to the emergency room. If you are in crisis, if your kid has 104-degree fever, which mine had the other day, you're going to go to your trusted primary care provider if you have one. If you don't have one, because that community health center had to shut its doors, you're going to go to the emergency room, which is more expensive. Community health centers, as a whole type of provider, they save the Medicaid system 24%. That's a huge cost savings. You want people to go to community health centers and receive integrated care. You don't want them to take primary care needs or something that could have been solved through substance use disorder treatment at a CHC to the emergency room, because it's more expensive in the end. There are community health centers behind me that would also like to speak to you, and so I would let them speak. But I just want to highlight the impact that community health centers have on the state of New Hampshire. 10 organizations employ almost 2,000 people. In direct jobs, they have over 1,000, 380 indirect jobs, and 420 supported jobs in their service areas. If we don't, as a state, solve the uncompensated care problem, the health centers have to shut their services, they have to let staff go through reduction in force, and they have to eat vacancy savings. We don't want that. Since Medicaid expansion passed, the health centers have seen over a 400% increase in demand for substance use treatment services. If the community health centers go away, where are people going to go? Thank you. I'd be happy to answer any questions, or you can ask the health centers behind me.
Any questions? Can you just run by, all right, go ahead, Senator. I'll ask my question last.
Yeah, this question may be, this is the knowledge that I don't have.
Sure.
Is substance use disorder included in mental health?
Senator Long, yes, we include, as a healthcare system, we include substance use disorder treatment as mental health services.
Okay, great. Thank you.
My question is, you listed off the percentages of uncompensated care, private, Medicaid, Medicare, uninsured. Can you run that by me again?
So, sure, Mr. Chair, that's their payer mix.
Yep.
And it's in my testimony. 36% of health centers' patients are insured through commercial insurance, 31% Medicaid, 19% Medicare, and 14% of their patients are uninsured.
Great.
And each pocket, if you will, incurs uncompensated care because health centers are required by law to provide services that aren't reimbursable.
Sure. Yes, thank you very much. Any other questions? No, thank you for coming in.
Thank you.
Aaron Sawicki, Harbor Care.
Good morning.
Good morning.
Thank you for having me, allowing us to speak today. My name is Erin Sawicki. I am the compliance officer at Harbor Care in Nashua. Harbor Care is an organization dedicated to breaking the cycle of homelessness through healthcare, housing, and veteran services. We house over 1,000 individuals and families throughout the state. We provide medical, behavioral health, including mental health care, dental care, to approximately 3,000 patients per year. And we provide over 500 veterans and their families with vital supports. Our health center is designated as a healthcare for the homeless program and is legally required to serve all in our community regardless of their ability to pay or insurance status. This results in large amounts of uncompensated care that we need to find a way to cover financially. In 2023, our uncompensated care totaled $3 million, and in 2024, $2 million. The financial burden of providing high amounts of uncompensated care is unsustainable. One example of a measure we needed to take in the past to relieve some financial stress was to make the difficult decision to eliminate positions within the organization. Financial strain pushes our employees to continue to do more with less, ultimately jeopardizing patient access and resulting in less time for providers to see their patients. This is particularly challenging for us at Harbor Care because our patients often come to us with complex needs that need more time to address. At Harbor Care, we provide preventative care as well as treatment for substance use disorders. Every day, we're moving people towards better health and recovery. This means every time we care for a patient, we are reducing downstream costs for emergency and urgent care. Supporting the uncompensated care pool for federally qualified health centers not only helps to improve the health and well-being of our most vulnerable community members, it makes financial sense for the healthcare system as a whole. I'm happy to answer any questions.
Any questions? Senator Long?
Thank you, Mr. Chairman. Now, Harbor Care, I believe, has a program with the city of Manchester on veterans. Is that correct?
We do, yes.
Okay.
Yes.
Now, with respect to homelessness, is some of this uncompensated care, mental health to the homelessness? For example, this veterans program that we have. I'm trying to figure out what percentage would be mental health in that program.
Sure, I think I can try to answer your question. So the uncompensated care totals that I gave you were specific for our federally qualified health center. The veterans programs that we have, for example, the one that you mentioned in Manchester, are separate from that. So they do receive some of their health care through the VA still, but the amounts that I quoted were specifically for our federally qualified health center, which is a separate funding stream from the veteran services that we provide.
Okay, great. Thank you.
Questions? No, thank you very much.
Thank you.
Chris McCracken.
Good morning. Welcome.
Thank you, Chairman, and thank you, committee members. Grateful to have an opportunity to speak to you this morning about the structure that's being proposed. Federally qualified health centers have been covered for you broadly. We have about 17,000 patients in the Manchester area. And mental health, substance use disorder are a huge part of what we do. We actually have about 24 primary care providers and 24 behavioral health providers. We have had behaviorists in the schools providing access to care, and we also offer substance use disorder and behavioral health services within the clinic itself. For us, the ability to cover people, 89% of our patients live at or below 200% of poverty. So whether they're insured or not insured, they often qualify to get our sliding scale. So if somebody has Medicare, but they're elderly, they have a fixed income, that 20% of their whole bill is really hard for them to pay when they have limited resources. They can apply and get covered by the sliding scale that we offer to patients, which brings that copay down to a more livable amount. So as Christine was presenting from Bi-State Primary Care Association, those funds add up over time when you have several people who are accessing those services. We had about 1,000 patients fall off of Medicaid during the public health emergency, but over the last 28 years that I have worked at the federally qualified health center of Manchester, Amoskeag Health, we have had anywhere from 25 to 27% uninsured patients down to 16 or 17%. It's a very fluid process for patients. As you probably know, even from your own employers or your own past, you could have Anthem this year, you could have Harvard Pilgrim next year, you could move to a different job for have a period of time where you don't have any insurance. People kind of move in and out of payer categories, and having the consistency of a mental health clinician, a primary care provider that you can see regardless of your ability to pay is critical. And we never turn anybody away because they can't afford care. So for us, the ability to maintain what we're doing. We've had really flat funding or decreases in funding from other sources and constant nonstop increases in cost to maintain the biggest expenses for us, which are staff and benefits themselves. So for us, in response to some of those shortfalls, and we had a $3.9 million loss last year, to give you kind of a sense of scale, we closed one administrative site, we closed one clinical site, we collapsed people into other existing locations, and we've reduced staff by over 40 FTEs in the last 2 years, just to make sure that we could live within our own means. But were it not for the Gopher funds that we were able to receive in the last year, we would have had to reduce things even further. We want to make sure that we can be there because we realize, much like was explained earlier, if we don't provide the care at the most cost-effective means possible, they will end up needing the care in the most expensive means possible. And that's going to get passed on to all of us. Right, so to take care of the patient in the safest setting at the lowest cost that we can possibly provide is really ultimately our goal. So if we don't establish a mechanism to start closing these cost gaps, most of us in the safety net structure, the 20 mental health centers and the 20 federally qualified health centers, we're going to have to continue to reduce programs and close access points. And so that cost will end up needing to be covered, and all of us will end up having that passed on to us through the means that we're talking about. We would prefer to do this in a structured and planned way in collaboration with our partners that do the work in mental health and with the agencies that are involved in this process. And I'm happy to answer any questions that I can.
Sure. Any questions? Senator Long.
Thank you for your testimony. So the Gopher funds with respect to mental health are appropriated till when?
Those funds have to be spent down by, I think, the end of this fiscal year.
25
Which
or
is
26?
Yes,
12/26?
right, because those were the funds
yep.
to support COVID, and as we know, those funds go away.
Okay. And with respect to Amoskeag Health, there's mental health centers. However, you're federally qualified mental health, so there's two. There's the states.
There's federally qualified health centers,
Yeah.
which provide primary care, mental health, and other specialties core services to uninsured as a safety net system. And there are community mental health centers, which include the programs that were being presented at the beginning of this hearing. And we usually collaborate in our communities around how we provide that safety net care. The mental health centers assist us with supervision of psychiatric nurse practitioners and other clinicians, who often help us with grand rounds. And then we also have our own providers in-house. And even with those two, we're not meeting all of the needs that are there, but it's certainly a great system of care. And we very much appreciate that the need for those mental health centers is there as the other safety net provider in our community.
Okay, great. Thank you.
Thank you.
Thank you very much. Ken Gordon.
Good morning.
Good morning. Mr. Chair, committee members, thank you for the opportunity to speak with you today. My name is Ken Gordon. I serve as the CEO of Coos County Family Health Services. We serve approximately 12,500 residents of Coos County and northern Grafton County. We provide primary care services, dental services, and behavioral health services. Thank you for the opportunity to speak on Senate Bill 136 and the notion of establishing an uncompensated healthcare fund. It's difficult to extract the community health centers from the community mental health centers. In fact, there's kind of a blending of the two. Several of our community health centers, or FQHCs, operate offices within community health centers. There's been a move to integrate primary care and behavioral health for many years now. And from both directions, both primary care and mental health, there's an attempt to try to cross that bridge and understand that the head is in fact connected to the rest of the body. So we would encourage the committee to consider a broad definition of safety net provider because it is difficult to distinguish and separate the work of the community mental health center from the work of the federally qualified health centers. As Commissioner Betancourt mentioned earlier, there is a crisis really in the safety net provider network. In our organization, we had uncompensated care of approximately $1.8 million last year and suffered a loss of $1.2 million in profit. We're required by law to serve everyone, just as community mental health centers are. And so that leaves us with few options in terms of closing the door. What we have done, as you've heard others discuss, is we've had to cut back staff. So we've had staff layoffs in the neighborhood of 10%. And we've looked for other efficiencies throughout the organization. But those deficits aren't going away. And as others have mentioned, the notion is that the cost will be transferred if we are not able to serve people in a lower cost setting like a primary care health center or a community mental health center. So while we are also providers who pay health insurance premiums and are very sensitive to that as well, we're also sensitive to the fact that those premiums may go up if people are not able to get care at the primary care or community mental health center level. I'd also encourage the committee to drill down on the definition of uncompensated care. There are a number of definitions out there, and I think it's super important that we get a clear definition that we're all speaking about. Well, thank you for the opportunity to offer my testimony today, and I'm happy to answer any questions.
Great, thank you. Are there any questions? Oh, thank you for coming in.
Thank you.
Bob McLeod.
Thank you, Mr. Chair, committee members. Bob McLeod, I'm the CEO of Mid-State Health Center. We're located in the middle of the state, Plymouth, Lincoln, and Bristol. A lot has been said today about the struggles we all have as safety net providers to make ends meet, and I'm not gonna be redundant. All of that has been said. I will say that it is difficult to separate all sorts of services, whether they be mental health, primary care, oral health, all of that needs to be done. And also it was mentioned that, you know, maybe some organizations, hospitals maybe can do cost shifting. We can't do cost shifting. All of our service lines are barely making it, if at all. So last year we lost $720,000, and on a good year our margins are very, very small, maybe 1%. So what happens is eventually, if we don't really work on this whole thing of compensated care, a lot of safety net providers are gonna disappear, or they're going to have to limit the services they provide. Once the services go, no matter what, once the services go, they will not come back at all. So I ask that the committee look at this legislation, work with this legislation, and consider all of the safety net providers that are there. We're all doing a great job with minimal resources to do that. So I thank you very much. I'm not going to spend any more of your time with this, but would be happy to answer any questions.
Thank you. Are there any questions? No, thank you very much.
Thank you.
Sabrina Dunlap.
Thank you, Senator Rochford and members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem, and I will be very brief. I'm a little confused, and obviously it needs some clarification about the scope of the bill, whether it is just mental health or, to Christine Stoddard's point, about safety net providers. We have some other concerns and questions about the bill as written as well. I do just want to say we recognize and deeply appreciate the role of CMHCs and FQHCs and the incredibly important work that they do. We have been at the table in sort of other contexts discussing ways we can make improvements to access to mental health care. Would love to continue to be part of those conversations. I know quite a few of the people behind me who I plan on touching base with to see if there's work we could do outside of the legislative process to try to help. So I just wanted to say that. And I do think there needs to be broader discussion about how to address the situation that Christine Stoddard outlined about the FQHCs and the other concerns coming from the CMHCs. I think it needs broader discussion. I don't think the approach of just doing an assessment on commercial insurance is the best route to take, but would love to be part of further conversation. So thank you for the opportunity to speak and happy to take any questions.
Thank you. Any questions? No, thank you very much.
Thank you.
Jenny O'Higgins. Good morning.
Good morning.
Welcome back.
Thank you. For the record, I'm Jenny O'Higgins. I'm a legislative liaison and policy analyst for behavioral health at DHHS. So as you've heard a lot of this morning, the community mental health centers were hit significantly by the Medicaid unwind that had been able to continue coverage throughout the pandemic. And people then no longer qualified. They did continue, however, to provide services as they always do in the CMHCs serve all. So they serve now those uninsured people. So over the past several years, the CMHCs have continued to struggle with staffing, which contributes to lower operating costs, but also creates fewer opportunities to generate revenue, and has contributed to our wait lists and things. So as you all have heard so much about this year, this is very related to our work with our 10-year mental health plan and our Mission Zero work in terms of having community mental health centers that are able to serve all and are able to provide care that is really improves the quality of care and reduces some of the unnecessary costs in terms of people going into emergency rooms or needing more costly residential type care or higher levels of care. So in August of 2024, GNC approved a contract, an award of $5 million to address some of those losses that were experienced by our community mental health centers. And the department used that $5 million as the basis for a prioritized needs request. So wanted to make you all aware of that. However, as you have heard from others, including our community mental health centers, the operating losses indicate that uncompensated care does exceed that amount, and that is the amount that is in as a prioritized need. Additionally, that $5 million in the prioritized need would support the costs associated with delivering integrated physical and behavioral health care by the state certified community behavioral health clinics that serve individuals across the lifespan with any mental health or substance use condition. The goal of that program is to improve the health and wellness of New Hampshire residents who are experiencing mental health or substance use challenges and to reduce these more costly settings, as I previously mentioned, and that can alleviate the need for inpatient acute psychiatric beds at New Hampshire Hospital and at our designated receiving facilities. So the community mental health centers really are the foundation of community mental health services in the state of New Hampshire, and they're offering rehabilitative services. I think there was a little confusion earlier about are there additional services that are social services or things like that. These are things like wraparound services, functional support services, targeted case management that are a part of medically necessary care. And so just because we sometimes talk about them differently, I just want to make sure that it's clear that we have determined that they're necessary to cover through Medicaid, and that the state does pay for some of the services for those that are uninsured. So, and that is, again, because they contribute to lower costs in other areas and because they help people go on to get well. So the New Hampshire can anticipate that there's going to be an increase in uncompensated care burden in our healthcare systems as we go forward. And we were not asked to do a fiscal note worksheet on this, but just wanted to make sure to provide the prioritized need request information to you all. So I think that's all I have for today.
Senator Bertzel.
Thank you. So you said that it's in the prioritized needs for the budget of $5 million. What would be, how much do you think in addition to that 5 million?
What we've heard today from the community mental health centers was that their uncompensated costs were more in the range of 15 to 19 million. And I know that they had broken out some of that in terms of which parts are driving those costs. So in terms of this legislation, as I understand it, is not to cover all uncompensated care, but just the uncompensated care for the commercial payers portion. And so they would be able to better break out what number that would be. What we based the prioritized need request on was that the award that went through GNC in August 2024 to at least continue the portion that we have covered as a state previously, so that part wouldn't be going away.
Thank you.
Any other questions? No, I think we're all set. Thank you very much.
Thank you.
So I had one more question for Roland Lamy, if you had a minute. And we've heard a lot of terms and a lot of numbers and a lot of things thrown around today, and I just wanted to maybe pin this down if you had the answer. What percentage of your clinics' uncompensated care is from patients who are covered by a commercial plan that just doesn't cover the services? Do you have that number?
So in
Or
the,
it might be in your testimony and I haven't,
no, so
had a chance to look at it.
in that spreadsheet that I reviewed, our total uncompensated care is about 15 million. The amount associated with commercial and Medicare bad debt was about 5.5 million, and then write-offs for services provided that are not covered is another 3.5. So roughly 8.5 million out of 15 million.
Is commercial.
Yeah, I mean, there's some other things in there, to be fair, self-pay, Medicare deductibles, those kinds of things.
Okay. Great. Thank you very much. Sure. That concludes our list. Is there anyone that has not spoken that would like to speak on Senate Bill 136? With that, I'm going to close the hearing. Thank you.
You're doing a great job.
All right, Sophia, you ready? I can't hear you.
You have a lot?
Yeah. 10. I gotta be somewhere.
I got a committee at 2.
Yeah. All right. We've got somebody else coming into this meeting room after us, a subcommittee. We've got other commitments. So following Senator Bertzel's introduction, we're going to limit testimony to 3 minutes this afternoon. So with that, I'm going to open the hearing on Senate Bill. Let me find it. Senate Bill
128.
128. Relative Children's Mental Health Services for persons 18 years of age and younger. Senator Bertzel.
Thank you, Mr. Chair. Thank you, committee, for hearing Senate Bill 128. For the record, my name is Regina Birdsell, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I'm honored today to introduce Senate Bill 128 relative to children's mental health services for persons 18 years of age or younger. This is a rare piece of legislation that both increases access to behavioral health services and saves our state money. For several years, the New Hampshire legislature has attempted to address the disparity in insurance coverage for families and systems together, which is Fast Forward, New Hampshire's program that provides youth and family-driven wraparound services focused on keeping the child and youth in their home community. Most recently, Senate Bill 411 created a study committee to identify gaps in coverage for children's behavioral health services and provide recommendations to address those gaps. And Senate Bill 128 is a direct result of those recommendations. Fast Forward is only covered by New Hampshire Medicaid at this time, but not by private insurance carriers. However, every child in New Hampshire has access to Fast Forward program that needs it, regardless of insurance provider. That means that taxpayer general fund dollars are being used to cover the cost of the program for children with private insurance. Together with intensive in-home supports, crisis stabilization services, and the Fast Forward program, the total expense to taxpayers for covering services rendered to otherwise privately insured children is significant. Fast Forward is an important piece of our children's system of care and an evidence-based practice, meaning that we know it works for families. In this program, a Fast Forward care coordinator facilitates a family-centered planning practice for youth and their families who are managing significant mental health challenges. It is essential that families who are experiencing behavioral health challenges have access to this program, regardless of their insurance carrier provider. Senate Bill 128 creates a public-private partnership to fund this critical program. Under this model, federal, state, and private funding is braided to create a system that both prioritizes the health of children and saves insurers money on services otherwise covered for their members. This bill creates an association to assess carriers proportionately for children. Here we're with the assessments again, but proportionately for children who could access Fast Forward on their respective plans. The assessment ensures that the cost to private insurers is equitable as opposed to a mandate where only some insurers would be forced to cover the program. Additionally, the proposed legislation updates parity review requirements to include specific analysis of services available or missing for the 0 to 8 population and more specifically the 0 to 5 population. While a plan may achieve parity overall due to the nature of how parity is evaluated, these populations may still face disparities in available services. It is necessary to determine whether these populations have access to the services they need or if there are barriers due to insurance coverage that can be alleviated. Implementing a public-private partnership stops the state from having to subsidize private carriers to ensure that all children in need have access to this service. Treating children in their communities results in long-term savings to the state and to insurers. Additionally, when children receive earlier and less intensive interventions, they have a better long-term outcome and avoid more costly interventions such as psychiatric hospitalization. Senate Bill 128 is a win-win for our state, saving money and better care. And Mr. Chairman, I did learn on Friday that the insurance providers apparently received the Department of Insurance worksheet before a complete fiscal note has been done. We are still waiting for DHHS's input, so I'm asking for a bit of grace period so I can get a complete picture of the cost before we exec.
Thank you.
With that, I will end my.
The theme of the day is assessments. You're right.
That's right.
Thank you. All right, the next speaker we have Andrew Hosmer. Welcome back.
Thank you, Mr. Chair. Thank you, members of the committee. And thank you for Senator Birdsell for her work on this bill. My name is Andrew Hosmer, representing Harvard Pilgrim Healthcare. New Hampshire's largest nonprofit health insurer. Harvard Pilgrim is opposed to this bill, which we are concerned would place a potentially large assessment on commercial carriers for behavioral health services for children and adolescents. Some of these services, which we cover already, including in-home services, residential treatment, and structured outpatient programs. As you know, there was a similar coverage mandate that was introduced last session. Just as a little background, the insurance department convened a stakeholder work group to discuss many of the services listed in the bill, which culminated in a bulletin in early March 2024. The bulletin required carriers to produce usable guidance that explains to providers how to bill for services that are reimbursable under the children's commercial coverage. In response to that directive, we updated our payment policy in late May and published notice to providers in October in our provider newsletter. One of the concerns that we have here, certainly we do not argue with the goal of high fidelity wraparound services, but our concern here is that currently Harvard Pilgrim does not cover functional support services. Functional support services are not clinical services and thus not covered under our commercial insurance. Also, I'd like to point out that Section 3 of the bill amends existing state law related to mental health parity filings by commercial insurers, requiring that every comparative analytic be separated by age groups and requiring a slew of different data metrics that need to be done for each would be an enormous administrative burden for the plans. This is inconsistent with the requirements under the MHPAEA, which does not require plans to do a litany of analytics for every comparative analysis or to separate treatment limits based on age. This clearly goes well beyond the federal rules by attempting to create new benefit classifications that are not provided for under the MHPAEA. This law creates 6 benefit classifications, none of which are based on age. Those being inpatient in-network, inpatient out-of-network, outpatient in-network, outpatient out-of-network, and emergency services and pharmacy. With that, we are certainly, though we oppose the bill as written, we are certainly willing and able to continue working along with the prime sponsor and other stakeholders to take another look at this bill and maybe another run at it. With that, I conclude my remarks. Happy to take any questions, Mr. Chair.
All right, are there any questions? Is that a yes or no? Oh, okay.
No, I think you're all set. Thank you.
Thank you, Mr. Chair.
Michelle Heaton and DJ Betancourt.
Thank you, Mr. Chairman, members of the committee. My name is still DJ Betancourt. I'm still the commissioner of the New Hampshire Insurance Department. I'm going to try to stuff as much information for you here in 3 minutes as possible. So I think, as I mentioned before, this topic has a bit of a history, and I think that the dialogue here has shifted in a better direction in the sense that when we've had the conversation around these services before, they were typically under the context of them seeking to be mandated. And that opens up a whole host of different problems, not the least of which is federal requirements for defrayal around those costs. So the implications of that were going to be fairly significant. And it has also, I think, helped us to better understand the types of services that we're talking about here. So my understanding is that the Fast Forward program is implemented or those services are provided by 2 providers in the state of New Hampshire, and I think both of them are represented here today. They are bundled services, and from what I am told and from what I understand, it is incredibly difficult to pull apart those services into their individual components. Because, as I mentioned before, I think in the past we've always talked about this in the sense that, all right, well, some of those services within the bundle are your typical clinically defined type of services that commercial insurance will cover. So those services should be covered. You should be able to bill for them as the provider. But some of these other things, the functional supports, if you will, are typically things that are outside. But because of the bundled nature of that program, it's hard to do that, from what I'm told. So we go back to the assessment issue. Again, I'm not a fan of an assessment. There is, I think, a notable difference, though, between this proposal and the one that you just heard. And that is, we'll certainly work with Senator Birdsell on some adjustments to the language to make sure that this, in fact, is the case. But my understanding in conversations that I've had with the advocacy groups and with the centers themselves around around this proposal is that in the end, the assessment would have to be somewhere in the range of approximately $2 million. Now, again, you're going to want to make sure you've got guardrails in there so that you're containing that cost. But that obviously is a much different proposition than what you heard previously. So again, not a fan of the assessment, but it is at least contained. And ultimately the decision is, you want to make that investment for these services for these kids. The only thing that I'll say though is if you do move forward with the assessment, again, I think the $2 million is reasonable and we can help you keep that so. You've just got to be vigilant about the potential precedent that's set in the sense that you do not want to have it become the case where every advocacy group, a set of providers, sorry, do you want me to continue?
You can finish your thought.
All right.
Yes.
You don't want to have a situation where you're going to have a whole host of different providers coming in looking for an assessment to cover their particular services. That becomes, I think, very, very difficult. These assessments are rare. We use them in very rare circumstances. There's a component of this that impacts DHHS's Medicaid budget. They can speak to that, but obviously, to the extent that we can be helpful in alleviating that problem, I would certainly like to try to do that.
Great. Thank you.
Thank you.
Question.
Yes, thank you, and thank you for testimony. Functional supports was a critical, how critical is that part of this bill? The functional supports?
Sorry, can you repeat the question?
What?
Can you repeat the question?
I apologize, yes, functional supports was brought up and making it, according to previous testimony, that this being a very big roadblock. How critical is that to this bill?
So again, the challenge you've got there is the Fast Forward program has a whole set of services that the child is wrapped around in. Some of those are, like I said, some of those are things that are within the typical definition of clinical services. Others are outside. My understanding, and the providers can certainly speak in more detail as to exactly what their program looks like in the services that it provides. But they would range from things like helping the child organize their day, help the child organize the grocery list, or things of that nature. Certainly, those have values. There's value to those services for the child, but they would fall outside, as I've said, of that traditional clinical definition for services.
I think one of the issues we see with the bill is that there's not specificity and it just refers generally to program costs. And it's not defined what exactly those program costs are. So I think, putting some more parameters around that would make it helpful. Also, we did create a fiscal note, but we don't know what those program costs are. So it's really just a calculation. And then we would need to know what the program costs are in order to put them into the calculation to figure out what exactly we're looking at.
And we'll redo that analysis. I mean, again, the benefit of this particular proposal is you're only talking about 2 providers that render these services. So it should be easy to be able to figure out who we need to talk with and work with to drill down on those numbers.
Great. Thank you. Anything else? Thank you very much.
Thank you, Senator.
Sabrina Dunlap.
Hi, my name is Sabrina Dunlap, Senior Director of Government Relations for Anthem. Thank you very much for the opportunity to speak. I have a lot to say on this because I have been involved, like many others behind me, in many conversations for quite a few years around mental health services and various mandates. So I'm going to jump and cut a lot of what I was going to say, since Andrew already mentioned the bill last year, SB 411, and the bulletin that the insurance department did. As part of that bill, there was a stakeholder group that met from starting in last January through the summer. And we did a side-by-side comparison of the mandated services in the bill compared to what commercial insurance covers. As far as I understand, we did not identify large gaps in what was covered. There was some confusion around coding that we worked on, but in terms of the services, commercial carriers generally cover what we consider wraparound services. And so what came out of those discussions that I want to flag is this discussion around Fast Forward and the notion that somehow commercial carriers are a drain on that program. And I was confused by that because that is a DHHS program administered by DHHS through 2 care management entities. There's only 2 in the state. And when I did a little digging, realized neither of those care management entities are in network. As far as I know, with any commercial carriers, they're not in network with Anthem. And so, you had 2 entities administering a program that commercial carriers had nothing to do with and really no knowledge of and no engagement by DHHS. And then we were being told that we were a drain on the program somehow. So I engaged with the 2 care management entities and had a very lovely conversation, in-depth conversation with them last spring. And it came to light, one of their challenges is that they don't come in network with commercial insurance, in part because they don't have the volume of commercially insured patients to serve. So it doesn't make sense necessarily for them to come in network. But sorry, I'm jumping around here. So, I think it's an incomplete picture at best to say that commercial carriers are a drain somehow on that program. It's not as if Fast Forward is some like off-the-shelf program that commercial carriers could start covering. It is very specific. Again, it is administered through these 2 care management entities that we do not have a contractual relationship with. And I also think it's important to point out that when we did the side-by-side comparison of the services in SB 411 last year, we largely do cover most of the services that you would find in Fast Forward. So I think it would be a helpful exercise maybe to identify if there are still remaining gaps, things in Fast Forward that we could potentially try to cover. I do not think this assessment approach makes sense in this circumstance. I have a lot more concerns with the actual bill language that I will not get into because of time, but would be more than happy to continue the conversations with the other stakeholders as we have for many years. So thank you very much for the opportunity to speak.
Thank you, Sabrina. Questions from the committee? Senator Birdsall? No?
No.
Thank you. Patricia Tilley. Testing 1, 2, 3. Welcome. All right.
Apologies. I will be sitting in for Patricia Tilley today as well.
Okay.
From DHHS. She had to leave. So once again, for the record, I'm Jenny O'Higgins. I'm a legislative liaison for behavioral health at DHHS, and not Patricia Tilley, unfortunately. So Fast Forward provides a youth and family-driven wraparound service, and it focuses on keeping children and youth in their home communities and establishes some individualized care plans for their mental health challenges. So that work is done to identify the most appropriate services based on the underlying needs of the child. We have done our fiscal analysis, and I know it's not yet attached to the bill, so I just wanted to be sure to go over that with you all today. So there are about 20% of families that are currently served by those 2 care management entities in the Fast Forward program that actually have private insurance. So the care management entities are successfully connecting 75 to 85% of those families to Medicaid through the Katie Beckett insurance, the HCCSD. But there is a cost accrued either in the interim or for those families who are not eligible for that Medicaid benefit for youth that meet criteria that then removes the parental income component. And so those costs are upwards of $2 million annually that are covering kids that are getting Fast Forward services that are commercially insured. And we determined a range between 2 and 3 million for our fiscal note worksheet. What's included in that range is both the amount, the CME costs, those care management entities, their costs of the 20% of kids that are being covered by, are getting Fast Forward services, but are commercially insured. And that range was between 1,100,000 and 1,900,000 over the last 4 years. So we have that as our baseline, as between 1 and 2 million. But then we also added the additional costs that have been exceeding the maximum, where we have a $2 million max threshold in our contract with them. And that has been, those costs have been exceeded to the tune of $500,000. There's also a couple of determinations, components in this assessment determination section of this bill that need additional funding, including a 10% reserve and the board's plan of operations and additional capital working reserves. So we worked those in to get to that place of 2 to 3 million range. And you will be getting that fiscal analysis so that you can actually read through all of that. I know that I can't take in numbers when they're just lobbed at me verbally. So I will make sure that I actually get that information to you all, but I just wanted to give you a reason for why that range of $2 to $3 million. Happy to take any questions.
Thank you. So previous testimony said that fast forward was covered, but did I understand correctly? It's up to 75 to 85%? Is that?
I'm sorry, the fast forward is covered. It is covered by Medicaid and is the state does pay for fast forward for all youth. So it is open to all kids and will be paid for. The component that is being paid for of children who have commercial insurance is about 20% of those in that fast forward program. And the 75 to 80% range was of those 20% who have commercial insurance, we get about 75 to 80% of them onto the Medicaid Katie Beckett program. And so that exists for families that are over income for traditional Medicaid, but their needs are complex and the youth are at enough risk they're at risk for residential treatment. And so they qualify under that Medicaid benefit. And we get about 75 to 85% of the commercially insured youth that we're serving in Fast Forward onto that benefit so that they're still covered. But there is a component of young people who have commercial insurance that aren't covered under that benefit. They either don't qualify or there are costs accrued in the interim while we get them onto that benefit.
One follow-up, if I may?
Yeah, absolutely.
And first time I've heard the word reserves. So 10% for reserves?
Oh, that's in this bill language where there needs to be a reserve within this fund that's being created. And so we just were made sure to factor that part into the fiscal analysis. So it's not a part of a cost that I already know that exists today. It would be that the fund that's created needs some amount of reserve. So we did factor it into our fiscal note worksheet.
Thank you.
But that's not a today cost.
Thank you.
I know
Any
this
further
is
questions?
confusing. Please.
Senator Birdsall.
So the 20% that we put onto into the fast forward who have commercial insurance, do we get any reimbursement from the commercial?
No. So they either qualify under that Katie Beckett piece or not, but we cover them either way. All youth are eligible to be in the Fast Forward program regardless of coverage.
Thank you.
Any further questions? Seeing none, thank you very much.
Thank you.
Next speaker, Holly Stevens. What's that? Good morning, or afternoon, I think it's afternoon.
Yes, good afternoon, Chairman, members of the committee. My name is Holly Stevens. I'm the Director of Public Policy at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people affected by mental illness and suicide through support, education, and advocacy. Now, on behalf of NAMI New Hampshire, I'm here today to speak in favor of Senate Bill 128. The most visible symptom of New Hampshire's ongoing youth mental health crisis is the boarding of youth in emergency room departments while waiting for inpatient care. In order to address this crisis, it is imperative that there is an investment in community-based services that prevent the need to utilize higher levels of care. You have heard about the Fast Forward program a bit today. It is intensive, family-focused services that can prevent the necessity of a hospitalization for children and youth that are experiencing serious emotional and behavioral concerns. It's an evidence-based program that provides youth and family with wraparound services that focus on keeping the child and youth in the home and the community. And as a provider of family peer support services through this program, NAMI New Hampshire can attest to its firsthand to its positive impact of these services. And these are services, the family peer support services that NAMI New Hampshire provides are services that are not covered by commercial insurance in any way. Currently, private insurance carriers do not cover any of these services under the Fast Forward program. And despite not having coverage, as you've heard, these services are covered at the expense of New Hampshire taxpayers, with funding through the New Hampshire's Children's Behavioral Health Bureau, which is concerning because, as I said, it's on the backs of the taxpayers because commercial insurers are not paying for these services. Rather than waiting for a child to be sick enough to be hospitalized, if commercial insurance paid for these services that their members are receiving at the cost of the state, the family could receive services earlier, potentially alleviating the need of hospitalization. And additionally, if the burden of the cost of these services no longer rested on the Bureau of Children's Behavioral Health, those funds could be reallocated to support the children's system of care in other areas. Therefore, we do support this bill. Senate Bill 128 aims to ensure that the needs of the most vulnerable population in New Hampshire, New Hampshire's youth, have the services that they need and are covered by their insurance plans. Thank you. I'll take any questions you may have.
Any questions?
Oh, thank you very much.
Thank you. Oh, but Susan Stearns from NAMI New Hampshire is here to answer any questions about the actual program itself if you wanted to ask, if you had any questions for her.
Great, thank you.
Thank you.
Emma Savini.
Good afternoon, Chairman and honorable members of the committee. For the record, my name is Emma Savini. I am the Children's Behavioral Health Policy Coordinator at New Futures. New Futures is here. New Futures is a nonpartisan nonprofit organization that solves problems through policy change. And we are here today in
Sorry, Emma, can you pull that microphone a little closer?
Yes, sorry. I have a very quiet voice, sorry. New Futures strongly supports Senate Bill 128 because it creates a reliable funding structure for wraparound, the Fast Forward program you've been hearing about, an evidence-based practice that serves families experiencing behavioral health challenges in their communities. You've heard about the success and the importance of the Fast Forward. I want to touch on that clinical versus non-clinical component, and to your question, Senator Avard, why those non-clinical functional supports are so critical to this program. Fast Forward utilizes a bundled system to cover both non-clinical and clinical services, and that's essentially like the secret sauce of Fast Forward. Fast Forward is really successful because families are wrapped around and connected to whatever they need, whether it be therapy or the traditional clinical services, or those non-clinical services that are something like case management or peer supports for both the parents who have never experienced a behavioral health crisis in their family, or the youth who's also feeling really alone and struggling with their own mental health problems. And these services are not a new thing for carriers to cover. In the cancer space, they cover cancer navigators, which are essentially care coordinators for people experiencing cancer. In the substance use disorder space, they similarly cover peer supports for both for people experiencing substance use disorder. And so not covering this for children, this children's population in the Fast Forward program, but covering it in those other spaces implicates parity issues. Additionally, I'll address the background of this bill. As you know and have heard today, Senate Bill 411 last year proposed a mandate to cover these services. I'll agree there were some issues with defrayal costs and problems with only looping in some of the carriers. The idea behind the assessment means that it equitably covers all carriers. So all carriers would be looped into this assessment and pay a small amount to cover these services. In addition to that, we have the work group that did meet frequently to go over those coding costs for functional supports through the community behavioral health centers. The difference is the carriers for Fast Forward are not contracted with the carriers. So that means they cannot bill the carriers for these services, even if there are codes available. So we all are kind of on the same page that these services are not covered by private insurance carriers, and the services are still available to families either through Medicaid, Katie Beckett, or HCCSD, or through state general fund dollars. I'll wrap up there and just say that these services are really critical to families and that the carriers are essentially already covering these services in other areas. It would make sense that they cover them for the children's population too. Happy to take any questions.
Any questions? No, thank you very much.
Thank you.
Kristen Shepard.
Good afternoon.
Good afternoon.
Esteemed senators, members of the Health and Human Service Committee, thank you for allowing me to take a moment of your time. My name is Kristen Shepard. I'm a registered voter and resident of Derry, New Hampshire. I'm here today to request the committee to support SB 128. That will require private insurance to cover a very important service, Fast Forward. By passing SB 128, this will allow families with any type of insurance to be provided with the opportunity of this extremely important mental health service. In 2021, my son Christopher began a series of trips to the emergency room. We would go in, be released due to there not being enough mental health beds in the state of New Hampshire. We would go home, hoping for the best. Things would escalate, then we would land back in the emergency room with a mental health crisis. This rinse and repeat pattern went on until the end of 2021, at which time our son went into residential care out of state. During that time, my family had the Fast Forward service. This was only possible because our son had Medicaid. The Fast Forward service was the first time my family felt connected to something that could truly help us. As a social worker of 30 years, I'm abundantly familiar with the mental health system in the state of New Hampshire as well as Massachusetts. However, when your own child is having their first psychotic event and having several mental health emergencies, it was difficult, if not completely impossible, to put my social worker hat on in order to navigate a very complex mental health system. While in the hospital, we always had a lifeline to our Fast Forward social worker through NFI and our peer support person at NAMI. Although our team was larger than that, just these two individuals always had a helping hand for my husband and I. We could only just watch our son in the throes of a psychotic episode with nowhere to turn. These two amazing individuals provided us with guidance. They provided us with an ear to listen to when we needed to vent over the situation and would help me in particular to think rationally in what I needed to do next for our son within the system. Any family in any sort of mental health crisis deserves to have all available resources to them. Mental health is found in every culture, every ethnicity, every class. It is completely bipartisan. Fast Forward can provide help to more families than just those on Medicaid. Understand that mental health isn't worse for those families with Medicaid. So why can't all of those in need be provided with the same opportunities and services? I'd also like to address the gentleman from Harvard Pilgrim where, and I quote, functional services are not clinical services. If my son is not functioning, we're in an emergency. So as a social worker, when my clients are not functioning well, I'm using my clinical skills to help them. I'd be happy to answer any questions.
Thank you very much. Are there any questions of the committee? No, thank you for coming in today. Thank you. Katie Lyon Pingree.
Good afternoon, Senators.
Good afternoon.
My name is Katie Lyon Pingree, and I am here today to urge your support of Senate Bill 128. This important bill would ensure that children and families with private insurance have access to critical mental health services that prevent traumatic, higher-level treatment. This is an issue that is close to my heart. As you may remember from the hearing on SB 255 last week, my son Matthew started struggling with his mental health in 2018 at the age of 14, after a terrible concussion during a high school wrestling practice. The concussion, which was initially treated as a medical issue, eventually spiraled into a progressive battle with severe mental illness. At so many points during our journey through the mental health system with Matthew, I wished our family had access to a program like Fast Forward. In the interest of time, I'll speak today about only a few of those moments. However, I am submitting a full written account of my family's story to further illustrate the importance of a program like the one in SB 128. I encourage you to read that full version so you can see how much of an impact Fast Forward can have for families like mine. In February of 2019, Matthew was diagnosed with depression by his PCP. So we worked diligently to connect him with a therapist. Unfortunately, Matthew's struggles were beyond her ability, and it ultimately was not an effective relationship. Matthew's mental health continued to deteriorate until he was in full-blown crisis and dangerously suicidal. In September of 2019, Matthew attempted suicide in his bedroom. Fortunately, my husband and I were able to interrupt him in time. Having already experienced the trauma of an emergency department during a crisis like this, my husband and I opted to sleep on Matthew's floor that night and try to get him an appointment with one of his providers the next day. When his psychiatrist returned my call in the morning, she insisted we bring him to the emergency room, despite our previous negative experience. Rather than work with my family to find a suitable alternative, this provider called 911 against our wishes. Police and an ambulance showed up at our house and took Matthew to Concord Hospital. My husband and I had to follow behind the ambulance in our car and weren't allowed to even see Matthew for almost an hour after arrival. As a parent who so desperately wanted to help my child, having an entire system work against us and not with us was maddening and painful. Once again, we found ourselves trying to make decisions in the emergency department while under duress. While staying in the emergency department, Matthew was involuntarily admitted to New Hampshire Hospital. Again, this process completely shut me and my husband out. I was told about the time of the hearing, but wasn't allowed to speak during it. My husband and I were desperate to find a treatment that worked for Matthew. Providers at the hospital explained the options that were available at the time in New Hampshire, but none seemed to fit the needs of our family. Matthew's therapist recommended we engage an educational consultant to explore treatment facilities out of state. I believe this decision was interpreted by the hospital as us not wanting him to receive care, which led to the mental health provider, whose job it was to find a crisis care placement for him, to threaten to terminate our parental rights. We finally decided on a treatment facility in Utah that we hoped for several reasons would give Matthew the greatest chance to improve and to continue his education at the same time. During the 10 months he was there, we traveled out to visit him as much as we could, but we still felt gutted and conflicted that we could not have found a long-term treatment that would have worked in New Hampshire. Deciding to send your child who is in active mental health crisis thousands of miles away for treatment is not an easy one. When he returned home, we fell right back into the frustrating cycle of trying new therapists and medications just to try to maintain the progress he had made in Utah. Anytime Matthew would start a new medication or see a new therapist or visit a new doctor, there was always an initial glimmer of hope. But over time, that hope would fade when things did not significantly improve and his struggles deepened. Furthermore, Matthew had disconnected from all his peers and community support network while he was away. It was hard for him to integrate back into his friend group or engage in social activities. We all felt powerless to find a solution. Our family is blessed to have the time and financial resources to try and help Matthew, And yet, despite this, it remained extraordinarily difficult to navigate the complicated and often unsupportive behavioral health system in the state of New Hampshire. Now learning about the various programs that would have been available to our family, like Fast Forward, amplifies my grief, knowing it didn't have to be like this. We might have had a case coordinator who would have guided us through the journey of navigating the complicated web of services and options that were available. We could have had additional family supports, people who had gone through the same trials we had and could stand by our side and provide encouragement. We could have had peers with the same lived experiences as Matthew to make sure that he knew that he wasn't alone in his mental health issues. Most importantly, all of this would have been available to us at home and with providers focused on our family's strengths. Instead, we experienced the worst and most devastating outcome. We lost Matthew to his mental illness when he was just 18. Once again, I am here today on behalf of Matthew, urging you to please recommend that SB 128 ought to pass so that Granite State families have access to Fast Forward when they need it, regardless of their personal means and resources. Thank you.
Thank you. Any questions? No, thank you very much.
Thank you.
Dennis Calcutt.
Hi.
Good afternoon. Welcome.
And for the record, my name is Dennis Calcutt. I'm the Director for Connected Families, one of 2 care management entities in the state. I do want to start first by thanking you all for your interest in this work. It is so important and it is so misunderstood in our state, our communities, and our society. And really appreciate Senator Birdsall for bringing this forward. This work, and I'll try to touch on some of the things that people referenced today so I can provide a little more clarity as we move forward, because I really think this is the only way we solve this is through collaboration. This is not, one group against the other. We're going to solve this by working together. But SAMHSA, the Substance Abuse and Mental Health Services Administration, funded this work, and it's been happening across the country for over 25 years. It's new to New Hampshire, but it's still, it's 10 years old. So why is Connected Families? Connected Families is a sub-government entity. We're governed by Cheshire County. NFI, who you'll hear from as well, is the other care management entity. But these dollars that come in from the federal level to support the starting of the system may speak to why we're not with the insurance companies yet. It's still new. It's 10 years old, in essence. But the values of a system of care to be family-driven and youth-guided, to be community-based, culturally and linguistically competent, and trauma-informed. So if we're going to be really focusing on the family, it will be about building a team around that family. And those functional supports that, and I understand that the insurance side, that's not something that fits into their bucket. Well, do we need to find a different bucket? Do we need to find a way to work together to figure this out? But it is NAMI New Hampshire providing peer support. So it's a NAMI representative. So like we have a care coordinator who's working with that family. And if you look at the outcomes of cancer for a child and mental health for a child, the life expectancy is the same. Unfortunately for the mother who just spoke, that was drastically different. But the life expectancy is gonna be 25 years less. So we really have to pay attention to that. If we provide care coordination, we really get at how do we support them. But if we have on that team, we have a care coordinator, we have a family peer support member, we have friends of the family, we have school people of the family. You bring the people together to support and solve those problems. But the other pieces that I want to touch on, one is, you think about that, it was referenced as Katie Beckett. I want to represent the family of Katie Beckett for a moment, because Katie Beckett has since passed away, and Katie Beckett's family said, please take our child's name off that program. It is HCCSD, Healthcare for Children with Severe Disabilities. And in that, the focus here is if a child's not on, may I ask for a couple more minutes?
Finish your thought.
Thank you, sorry. to be so long. But in that program, if we take a child in to provide care coordination and they have Medicaid, no problem. If we take a child in and they don't have Medicaid, the first step is to apply for HCCSD. And in that application, you're trying to determine the benefit need based on the disability. There is a factor in there related to income as well, but it's about the disability. And if we focused on the disability, we'd be in a different place. But there are some children and families that still isn't worked for. So in those cases, and those could be commercially insured, they could be uninsured, which I'd be a surprise to me, because isn't every child in the state of New Hampshire supposed to be insured? But if they're not, or if they have commercial insurance, the thing that I would say is very admirable for the state of New Hampshire is that we're providing them the care. We're ensuring that, because the greatest investment we can make is in children. Because if we can stop these problems now, we will be saving money for the state and providing people a healthier life as we move forward. Let me just make sure I'm touching on everything really quickly here. When we run into barriers like this, so the program is about 10 years old, and when we run into barriers like this, we need to come together to solve the problem. Because if we don't come together, we start to splinter, and we start to find that this part of the program starts to fall apart in a road, or this part of the car isn't working, and we don't repair it. This is when we have to get together and when we have to figure that out together. Providing this type of structure would provide us a fund and would provide us oversight. We're not saying, just give us the money. We're saying, let's work together to solve that. But it really is about that collaboration piece. To give you one crystal clear nugget in terms of how much it costs our care management entity, we are smaller than NFI. We cover the western third of the state. We have an office in Claremont and an office in Keene. Was $420,000. That was the loss for last year. So that provides it for us. Luke will be able to talk to you more specifically to NFI. But I really got to say, I just appreciate that you're interested in this. I appreciate that we're all here together to figure this out, but I think that's what it's going to take. Thank you very much for your time.
Great, thank you very much. Any questions? No, thank you very much. Last speaker we have signed up, Luke Raynal.
Oh, good afternoon. My name is Luke Renard. I'm the Executive Director of NFI North. We're a nonprofit behavioral health entity in New Hampshire and Maine. Like Dennis said, we are the other care management entity. We're quite a bit bigger. We do cover the entire state. I'm going to take a little bit of a different approach. I think the other testimony covered the philosophical basis and kind of the efficacy of the program. From a practical point of view, I think this bill is about equity. We received 602 referrals for Fast Forward in fiscal year 24. 167 of those were non-Medicaid. So 28% of the referrals and the people we're serving, we're not getting paid for. So in essence, we're getting paid 72% to do 100% of our job. So from a practical point of view, we lost money last year on this program. We're going to lose money this year on the program. However, I am very fortunate that we have the support of our board of directors who see the success that translates in the community. That can't be overstated enough about the outcomes of this program. Regarding some of the work groups last year, I think there were some issues around coding, around the functional support services, and how there aren't appropriate CPT or HCPCS codes for that. The issue is this is an evidence-based model. It has required components, and it doesn't work without all of them, right? But there's not a point where we're going to get the outcomes if we turn this into an a la carte menu. And that has been our issue with some of the private carriers. We'll cover X, Y, and Z, but we're not going to cover A and B because of the social part of that service. But for many families, that's the important part, right? Someone to listen, someone to help them through this that doesn't necessarily have a code. So, in support of this bill, I think it's important to look at the equity piece. There are 167 kids covered by private insurance that got an excellent service that reduced hospitalizations, that kept these kids in the community. In the insurance cover, they didn't have to pay a dime for it. We're glad to do the work because we see the outcomes. What we're asking is just for a fair approach to coverage.
Great, thank you. Any questions? With that, thank you very much. Is there anyone else that would like to speak on Senate Bill 128? Paula?
Thank you, Mr. Chair, and members of the committee. Thank you very much. And I'll be very brief because I know you've been sitting here for a long morning and listening to really good testimony. But I'm here on behalf of America's Health Insurance Plans, AHIP, and you heard from Anthem, and you've also heard from Harvard Pilgrim this morning. It occurred to me as I was sitting and listening, and I learned a lot this morning, that it might be helpful if you understood where care management entities fit in the scheme of things. They're actually referenced in state law, and the section of the statute that's important that talks about their function, I'm just passing out to you because it's a short one and will give you a sense of what the care management associations do. And as you've learned this morning, there are two of them. There's Connect New Hampshire, and there is also NFI. And those are the two agencies that you would come to mind if you looked at the provision I just gave you. So the other thing you might do is look at the bill and just look, most importantly, on page 2 of the bill, the definition on Roman 8, which is childhood behavioral health services. But you've heard about wraparound and you've heard about fast forward, but it may be important to really get a sense of what those services are. Because when the commissioner spoke, he talked about functional supports versus medically necessary insurance covered provisions of care. And that distinction has been a topic of great discussion way back to Commissioner Nicolopoulos and certainly with Commissioner Betancourt. And plans have met quite regularly at the department on the issue of trying to sort through coding that would simplify the billing practices for these entities who are finding that insurers don't cover what we sort of regard as functional services. And I think some of the gap between the understanding has narrowed, but there still is a gap. I first heard about this gap, I think Senator Avard would have been on the committee, maybe 4 years ago. And it came just as a matter of course when somebody from DHHS was speaking. And I remember thinking about it and saying, this is something I haven't heard about. It's a suggestion that insurance companies are deficient in some way in their generosity about these kinds of services. And then after that erupted the discussion. As I was listening this morning, I thought, now we're on the cusp of an assessment. The insurers right now are familiar with the non-federal share of the Medicaid expansion program, which insurers, I think, provide somewhere about $30 million a year on that. Or maybe, I would have to check that. I say that off the top of my head, and I'll get back to you with more specificity. There's an assessment called a 1332 waiver, which boosts the individual market. That is also an assessment on insurers. And then there's the vaccine fund. In fact, there's a bill later this week in Health and Human Services House that wants to eliminate the vaccine fund. So that discussion will go on over there. But the assessment mechanism in this bill largely mirrors the vaccine fund assessment mechanism. Looking at that, that is a, once that mechanism is in place, it's going to be somewhat immovable. And as the commissioner said, you want to be cautious about setting up an assessment mechanism. But I also say to you that I think there's an obligation on the plans and the providers to see if there's an alternative short of an assessment that would change that gap, i.e., are there a cluster of services, and you will find them at page 2, from lines 5 down to line 22. And that sort of outlines everything that these care management groups want. And is there a way that those wants could be satisfied short of an assessment? So I just want to say, I think it's important that the discussion continue. This is not a simple discussion. And I would say that AHIB would like to be at the table when that continues.
Great, thank you. Any questions?
Thank
Thank you
you.
very much. That's it. We're going to close the hearing on Senate Bill 128.